I'm really a fan of the fiber for anyone, particularly, fighting infections, whether it's flu-like viral infections or a urinary tract infection. We want to eat all the macros, most importantly, complex carbs, because they're feeding our lactobacilli and our bifido so that they can turn on the MBL system, the mannose binding lectin, which keeps Candida at bay and other fungal infections, whether it's BV and candidiasis or bladder and interstitial cystitis. So important to have this huge prebiotic, which also acts as a binder detoxifier. And ancestrally, we all ate these, many times a day. It's only lately, our foods are so hyper processed, and we don't get these special detoxifiers, and our gut lining starts to suffer as a result. For UTIs, the sitz baths are still really helpful. And even for interstitial cystitis, a hot sitz bath is really shown to be beneficial and pain killing. But for pregnant women, there's not a lot we really do. There's some safe antibiotics, and definitely they want to see their OB. Even some of the herbals, and I don't know too much, which ones are teratogenic or not. But a yin care sitz bath is still really helpful for recurrent UTI and using a vaginal and oral probiotic. And again, when there's recurrent UTIs, oh, sorry, I have a little typo here. We want to look at mycoplasma and ureaplasma. I'm going to go over a study about that soon for UTI and IC. So for urinary tract infections, there's a co-infection with ureaplasma and having chronic urinary tract infections. So this is not caught on a standard STI panel, and it's not caught on really any labs unless you specially order it. For people who are dealing with mold and co-infections like Lyme, Babesia bartonella, we do check mycoplasma and ureaplasma because these tend to cloud the picture. I asked my Korean doctor, my acupuncturist, how he would treat it. And he said, basically, you can never get rid of it. And I was like, wow, okay, that's like traditional Korean medicine. And he's right. These are intracellular pathogens, parasites. They're bacteria, but they're intracellular, like Babesia bartonella and Borrelia and other co-infections that are teeny tiny bacteria, and they're stealthy. They're stealthy infections. So we may not ever get rid of it, but by having a great homeostatic microbiome where it's not, disrupted with high fungal elements and other things, and a healthy immune system, these will be at bay. But what this study showed, there was a prevalence of ureaplasma and mycoplasma in the general population, usually 21% versus healthy controls 3%. So, for people with urinary issues, it's way higher, especially genital mycoplasma. They found a carriage rate of 39.4% in 4,000 people. And for chronic urinary tract symptoms, like for instance, for women who have chronic voiding problems, there's a carriage of 52.9% of ureaplasma, urolithicum. And there was a co-infection. 3% of these had also concurrently mycoplasma, MH. In Brazilian women, they looked at the urogenital tract, and MH mycoplasma was detected in 31.8% of those women, 302 women in that study. And ureaplasma was detected in at least one site or more in 81 women at a carriage rate of 52.9%. And there's a co-infection rate of 3.3% with 5 patients with mycoplasma. So they did a study, Baca et al. And his group, they are the group they treated. They did a single dose of erythromycin. They followed up in a month. If there was a persistence of the carriage, if the drug was susceptible, they did doxycycline twice a day for 7 days. And when they did the follow-up a month later, these people who were initially positive ended up 95.1% were negative on their cultures. Another remaining group, 4.9%, they were still positive, but they became negative after the doxy course. So their symptoms all got better as well when they got treated. So that's why I love some of the Chinese medicines combined with probiotics. We're not going to be driving, fungal overgrowth like the way this study probably did. And, it would be really interesting if they looked at these patients and did like a 1-year follow-up to see how much Lactobacillus crispus was still left in the vagina and the urogenital tract. I have a lot of questions, how much was this really a cure rate? Even though they initially saw it as a cure rate, what happened later? I'd be really kind of concerned. But it is really nice to know that these things can help. So men and women have this carrier state, and just like in mast cell and Lyme and in mold cases, we see a lot of co-infections. Really great to have a weeding, seeding, feeding program to minimize. Now, those with chronic interstitial cystitis, IC, they saw very high IgGs against mycoplasma. So in one study, Hadelin was looking at this. 56% of the patients who had high IgG to mycoplasma were chronic interstitial cystitis. Now, 7 of them had very, very high titers. And another group, they looked at antibodies to ureaplasma, and 19% were detected, and then only one person had a very, very high titer. So looking at titers, just like we look at mold IgG to different species of mold, or I look at anti-Candida antibodies, IgG, or when we are studying Borrelia or chronic activation of Epstein-Barr or CMV or HHV6 or HHV7, it's really nice to kind of see what the immune system's doing. It's a dashboard, and we can kind of track like what is the immune system doing. Is it completely correlated? Not really, not necessarily. We don't know. Because sometimes it could be a past infection, we don't know. But definitely, I think when it's flaring, like a high IgG can tell us like, well, that person might be dealing with it. And often I'll see when we work on it, it does, they feel better for sure. So for interstitial cystitis, my protocols involve, addressing some of this, how leaky is their gut? So for IC, that's pretty leaky, where you have calcification. So if they're tolerating, they can take lorazepam. They can take BPC if they don't have mast cell. And if they don't have mast cell, they can consider a TB4. But a lot of them have mast cell, and lorazepam might be the only safest peptide by mouth